Our next presenter is Dr. Neha Singh. She's from the London School of Hygiene and Tropical Medicine, and she'll be sharing some of her experiences mainstreaming gender and social inclusion in responses in humanitarian settings.
Thank you. Hi, everyone. Today, my colleague Kirsten Meagher and I are going to talk to you. I'm afraid we don't have a PowerPoint. We thought to be more informal, but we're going to talk about the role of gender-inclusive leadership during the COVID-19 pandemic to support vulnerable populations in conflict settings. And this is based off a commentary that we wrote along with Dr. Preeti Patel, who I believe is also on this webinar that was published in BMJ Global Health. And I'm just popping the link to that in the chat box now, in case you'd like to read further. But just to start, at the end of 2019, the United Nations High Commissioner for Refugees, or UNHCR, reported that an unprecedented 80 million people were forcibly displaced as a result of persecution, conflict, generalized violence, or human rights violations. And this number has almost doubled since 2010. Forced displacement is now affecting more than 1% of humanity. So that's 1 in every 97 people. And with fewer and fewer of those who flee being able to return home. 5 countries account for 2/3 of people displaced across borders: Syria, Venezuela, Afghanistan, South Sudan, and Myanmar. With COVID-19, the pandemic is overlaid onto already extremely volatile environments where conflict and humanitarian emergencies intersect. So who are vulnerable populations in these settings, and what happens in humanitarian settings to disrupt gender norms? We know that women are disproportionately affected by conflict and humanitarian emergencies. So of the 80 million I mentioned who are forcibly displaced at the end of last year, 3/4 were estimated to be women, adolescents, and children. Conflict promotes conditions during which existing gender inequalities and inequities are amplified. Community structures, access to healthcare, and human rights are all compromised, resulting in worsening conditions for women. Health consequences of conflict also disproportionately fall along gendered lines, resulting in high rates of maternal and neonatal mortality and morbidity and sexually transmitted infections. This growing evidence base demonstrates excess female morbidity and mortality, and reflects the necessity of evaluating the role of women in leadership, driving health research, policy, and programmatic interventions in conflict-related humanitarian contexts. Furthermore, this domain of conflict and humanitarian health also uniquely positions itself in non-permissive and often highly securitized and politicized contexts in which attitudes and assumptions toward leadership are predominantly male-normed and rooted in colonial legacies. Over to Kirsten.
Great, thank you for that, Neha. Hi, everyone, and it's wonderful to be here today. So I just wanted to highlight specifically our commentary as well, and why we wrote this commentary, because there's been a significant amount of attention that's been given to women political leaders in high-income settings, where it's been reported that women have led several countries' effective national responses to COVID-19. And we really wanted to highlight through our piece that cultivating and harnessing the advancements of women's leadership globally and implementing a gender-inclusive lens in pandemic preparedness and responses by including the experiences and voices of women in conflict is paramount, because it is extremely difficult to mainstream gender-inclusive policies in these settings, which we'll discuss as we go through. So the rationale behind this is that it will in turn create effective leadership models, as well as improving women and girls' access to adequate healthcare in humanitarian and armed conflict settings. So as Neha mentioned, women and girls are disproportionately affected by armed conflict and humanitarian emergencies. And this disproportionality has been exacerbated during COVID, where in conflict settings, we're seeing that one of the most affected and at-risk population groups include women and girls who lack decision-making power. During a pandemic, we see that resources for and access to adequate health services are further complicated. Of particular concern, resources to deal with the pandemic, as evidenced during Ebola and Zika, for example, are often diverted from essential health services for women and girls, so namely sexual and reproductive health, which has lasting effects for themselves and their communities. Previous public health emergencies have shown that the impact of an epidemic on sexual and reproductive health often goes unrecognised because the effects are not often the direct result, but rather the indirect consequences of strained healthcare systems, disruptions in care, and redirected resources. We do know that sexual and gender-based violence also increases during humanitarian crises, and access to support services are frequently halted or disrupted during pandemics. The International Rescue Committee has found through its analysis of gender-based violence that the suspension of these protection services for women, restrictions on mobility, lack of information, and increased isolation and fear have resulted in a dramatic drop in the number of reported cases of violence against women and girls in conflict and humanitarian settings. And of particular concern, we see Syria, Iraq, and Burkina Faso, for example, as the ability to report violent incidences are removed. Now, we also know that in these settings, testing capabilities for COVID are extremely challenging in resource scarce settings, many of which are affected by conflict and other humanitarian emergencies. A report again from the International Rescue Committee shows Yemen, Chad, Nigeria, Mali, and northern Syria are of particular concern with low testing numbers, which highlights the dangerous prospect of undetected and uncontrolled COVID outbreaks. But it also points to an even greater lack of access to testing and healthcare for women in conflict-affected settings. So despite their increased exposure to the disease as primary caregivers and healthcare workers. Also, the policies that have been implemented as a result of COVID reveal significant gendered impacts, and these are exacerbated in these settings. So policies of social distancing, self-isolation, hygiene measures, increased use of personal protection equipment. All of this is very resource intensive and difficult, if not impossible, to implement in many settings, particularly in refugee camps. So building on this, I wanted to discuss a bit more around Syria. So the current conflict in Syria provides an example of the difficulties of gender mainstreaming in COVID responses. As we have discussed, conflict disrupts community structures and gender norms. So in Syria, for example, prior to the conflict, some areas, particularly the major cities, there were more enablers for women to balance family and work. There were support systems embedded within culture, which with extended families providing support, for example. However, the conflict has fragmented families and communities, increased religious conservatism, and damaged family support structures, which creates an environment in which patriarchy increasingly thrives. Religious conservatism has been increasingly manipulated to preserve the traditional female role as a homemaker, contributing to increasing numbers of girls who are out of education or do not have opportunities beyond high school. And this contributes to other challenges, including early marriage and its associated risks. Women also face other challenges which relate to perceptions of their role within society. So although women have sacrificed a great deal during the conflict, their contributions are often less recognised than men's. So despite these tremendous efforts, since the Syrian uprising, women's participation in public, social, and political life is very limited and remains a contentious issue, which is further exacerbated by the politics of the various groups that control different parts of Syria. So across Syria, we see different levels of political participation, and in the regime institutions, for example, women's participation has been deemed tokenistic and uninfluential. In the Northeast, women hold senior leadership roles across policy functions and at all levels of their institutions. However, female leaders have to balance new policies with the views of conservative locals. And in the Northwest, we see a lack of female leadership. In opposition-held areas, there is no pretense of formal legal equality or legal protections made. And so all of this, it greatly impacts the role of women in leading in other areas. So for example, health and in the response to COVID. The Women Leaders in Health and Conflict Initiative, which I will discuss a little bit later at the end, held a webinar to discuss the role of women's leadership, specifically in Syria, and its importance in supporting the health needs of conflict-affected populations within the country. And during this, we discussed various barriers, but also a number of opportunities. So we know that in Syria, women make up a large proportion of frontline healthcare staff. However, healthcare personnel here face considerable risks due to the conflict. So from March 2011 through to February 2020, Physicians for Human Rights documented the killing of 923 medical personnel and 595 attacks on medical facilities. And so it's very difficult, though, to obtain accurate data on how many female healthcare workers are impacted and what their specific needs are. But we do know that they are a very important group that we need to support. So while the role of women in the Syrian conflict has meant that they are becoming increasingly influential in the public sphere and in shaping Syria's future, within the health systems, we still see there is a lack of female representation in influential leadership roles. And this is hindered by the various fragmented health systems, the political situation, a lack of support from colleagues, and restrictive provincial rules to female leadership. And we see some examples of this through the exclusion of women in health leadership. So in the Northwest, a female candidate applied for a role on the Health Board of Directors. However, the candidate was unsuccessful on the basis of not fulfilling the criteria, which was a criterion that was created to purposely exclude women. In Northeast, we see there are attempts to empower women in society. However, their role in influential leadership roles still remains weak. Where gender issues intersect with other disadvantaged groups, for example, individuals restricted by poverty or living in rural areas with low opportunities to access education, then this further marginalises women who are aspiring leaders. And the COVID crisis too has reinforced all of these barriers and the gender gap. So the COVID task force in northern Syria, for example, is underrepresented by women, with just 1 woman and some 30 men. So while the conflict in Syria has been a major setback for progress and gender equity, there is scope for pursuing activities that support the advancement of female leadership in health in Syria. So we know that using the resilience, strength and voices of women in the Syrian crisis must be made visible. So increasing the visibility of women role models locally and at the global level through social media platforms and advocacy groups is vital. Also, open and honest discussions can aid in shifting mindsets by challenging gender norms and unconscious bias. So rather than using negative views, last week we mentioned, I'm probably going to say this wrong, but mistajili, which is an Arabic term for she is like a man. So instead we can reframe these ideas and our perceptions of who a leader is, and that, you know, it can be a woman in her own right. And also any discussions on meaningful leadership must include decision-making power. And also the role of diaspora, international communities, international institutions and advocacy groups is really vital in engaging with women who are aspiring leaders. I'll hand that over to you, Neha.
Thanks, Kirsten. So Kirsten just talked a lot about sort of examples from Syria, so I'm going to contextualize what she talked about by giving a more bird's eye view of leadership and decision-making in conflict settings. We know that despite global commitments to improving gender equality, the subject of women leaders in conflict and humanitarian health has remained on the periphery of the global health agenda. Why is this? We know that in highly securitized and politicized contexts, attitudes and assumptions toward leadership are predominantly male normed, as I mentioned earlier. Gender equality in leadership inhibits productivity and performance within health and humanitarian systems and has individual and national health and socioeconomic impacts. We have research from various sectors, including from leading humanitarian organizations, suggesting that global efforts to protect and assist people caught up in conflict and national disasters will be more effective if more women contributed via leadership roles. I believe, Kirsten, you've led a paper on this as well. Women's representation and engagement in leadership roles would put women's issues at the front of the global agenda, challenge the traditional hierarchies of knowledge as well, and power by highlighting undervalued and unrecognized knowledge, and advocate for more inclusive, diverse, and representative decisions. Sarah Davies last week cited a webinar that, quote, you know, just adding women might not be enough on its own, but this may support developing and embedding gender inclusive frameworks and mainstreaming gender institutions. However, in general, very little is known about how women are contributing to health and conflict-affected settings, whether as healthcare workers or decision makers or in other roles. This is a barely researched topic, either via quantitative or qualitative research. Even less is known about what women's leadership might mean in such contexts. And we know Kristen just gave us some brilliant example of some research from Syria, but there's very little out there. We know that health is an area delivered by women and led by men, and that women from low and middle income countries comprise just 5% of leadership positions in global health organizations. Just think about that for a second, 5% of leadership positions in global health organizations. But in conflict affected settings, we have no substantive data available on the number of women in health leadership positions. So it's a bit of a black box. Therefore, we need more evidence-based research to drive this change. Including policy change. So thinking about policy and key actors, the multilateral system plays a critical role in establishing women's rights and gender equality as a global norm. Mr. Nee talked about that at the start of our webinar. And we're seeing this somewhat in the role of women's leadership in COVID responses. Research has also found that anything that undermines the multilateral system has a negative impact on women and on their position in society. So in 2019, the Global Preparedness Monitoring Board called for the involvement of more women in planning and decision-making as a vital part of sustainable outbreak preparedness efforts. Drawing lessons from previous disease outbreaks, such as the Ebola outbreak in West Africa from 2014 to 2016, as well as Zika, we know that women were less likely than men to have power in decision-making around the outbreak and their specific needs, which resulted in their health needs being largely unmet. Despite these lessons and recommendations, decision-making bodies established specifically for COVID-19 have not always reflected a gender balance. Analysis of recent emergencies have also clearly demonstrated that little has been done to actually ensure that women's voices are included in decision-making processes. And this has a serious impact in conflict settings too, as mentioned in the example that Kristen gave of Syria. So this is a call for diverse, inclusive leadership that is urgently required at local, national, and global levels to improve pandemic preparedness and responses in conflict settings and to mitigate their gendered impacts. Empirical research has shown that conflict and humanitarian crises create potential spaces to challenge these barriers. So women's rights groups, advocacy groups, and localized responses can facilitate shifts in power and resources and transform gender relations and empower women. For example, grassroots or community level leadership is an important way to challenge traditional leadership roles and to start to dismantle structural and cultural barriers. Creating strong networks is important, and enhanced collaboration between both researchers and practitioners will strengthen networks and increase evidence-based research that's urgently needed. Most critically, the voices of women in health and conflict must be made visible by first listening to them and documenting what they say, and then by amplifying them through social media platforms and advocacy groups. So to conclude, advancements in gender equality across the globe risk being derailed by the COVID-19 pandemic. And this will likely be further exacerbated in countries impacted by conflict, as evidence suggests. And Kristen and I have been both saying women and girls living in conflict-affected countries are particularly vulnerable to both the direct but also indirect impacts of COVID. Despite overwhelmingly working on the front line as health workers, the diverse needs of women and subsequently their families and communities are often not met as they're not included in these decision-making processes. I would also add that it's critical to apply an intersectional lens when thinking about gender and leadership in all settings, but particularly in humanitarian settings where these vulnerabilities are amplified. I mean, this is because women don't form a homogenous group. So when they're excluded in decision-making and policy implementation, other groups are also disadvantaged. Therefore, advocating for more women as leaders and decision makers at all levels in conflict settings is crucial to adequately address the gendered complexities of pandemics to better support vulnerable populations. Over to you, Kristen.
Great. So I just wanted to mention, just at the end, I had mentioned earlier about the Women Leaders in Health and Conflict Initiative, which a lot of the work that Neha and I are currently doing comes through this. And it's a partnership here at King's and at the London School. So, and it's a collective effort responding to this growing grassroots demand from women based in conflict-affected regions around the world to improve the health of conflict-affected populations. So the initiative adopts a unique position within the broader global movements working towards gender equitable leadership, focusing on a domain that is under-researched and under-resourced given the complex political, security and research environment that it's positioned in. So although there are significant barriers, which we have highlighted, preventing women from taking up leadership roles, we have also mentioned that there is a wealth of opportunities. So we really want to highlight and support the work of women leaders and the groups that they represent in conflict and humanitarian settings through this platform. And so a core objective of this initiative is to develop a diverse network that effectively translates research into practice by working in close collaboration with academic partners, NGOs, humanitarian practitioners, policymakers, anybody really that wants to be involved. So, you know, if this does sound like something that you are interested in hearing more about or getting involved with, then please do reach out to us. I will put something in the chat box as well about that. So thank you so much for this opportunity to discuss all of this work. Thank you.
No, thank you very much, Nia and Christine, for that very engaging presentation. And sort of, it's really alarming to hear about some of the figures you recited about people who were affected in humanitarian settings, and also how women and some of the issues they're affected by are marginalized. Also very interesting was your comment about not just focusing on getting women leaders, but also thinking through about intersectionality and making sure that multiple vulnerabilities are taken into account. So I'm sure your presentation is going to spark a lot of interesting comments and questions. So we're looking forward to seeing some questions in the during the question and answer session. So thank you again for your presentation.